I was going to try and say a few words in French. Then I turn around and I can see Rabbi Chawi chatting away lively in French, fluently. So I thought I would skip my introduction in French. So I just need to be able to get my computer. Can you switch on to my computer? Right. I'm sure you had a very good day yesterday, and you're going to have a busy day today. And we're going to start off with the ISUOG basic cardiac examination and fetal echocardiography. And I thought I would start by giving a differentiation between those two topics. There are two different aspects of my talk. The first is about screening, which is really suspecting that there is a problem. And that is probably what most of you would be involved in doing. That is, you get a large number of women who are low risk, and you have to try and identify those where there is a big problem, or a small problem sometimes. Then we have scanning, and that's just playing with the words, but for me scanning is more like you actually define the diagnosis the best you can and refine it to get the smallest details that may make a difference to the diagnosis and to the management of the pregnancy and the newborn baby afterwards. So how does that mix with our talk today? Well, the screening would be the ISUOG guidelines, which were issued in 2006, and that was divided into the basic and the extended basic cardiac scanning. And the fetal echo is really what was published subsequently, which is the consensus statement for ISUOG, a group of people that decided what constitutes a fetal echocardiogram based on their experience. So if we leave that aside for a minute, we're going to start with the 2006 guidelines. Now, that was divided into basic and extended basic, as we already said. I'm sure all of you are very familiar with this. 2006 is coming up to about 5.5 years since it was published, so it's quite a long time. And also, the guidelines reflect what is known at the time. ISUOG is an international society, and therefore any guidelines have to try and be very wide to be applicable to as many places around the world as possible. And that's quite a difficult task because some are more advanced than others in screening. So at that stage we had two levels of screening, and the basic one, which is really the minimum that hopefully everyone will be doing for low-risk pregnancies when they come to their 20-week scan. And these are pictures taken from the guidelines in 2006, and the cornerstone for any screening for the heart is the four-chamber view. And you can see a diagram here, and we'll go quite a lot about the four-chamber, so I'm just going to leave that still picture alone, and then start by, can you see well there? Do we need the lights down? It's okay. So this is, a very nice, I think, four-chamber view where you can see all the details. And it's quite nice to see here, and I think I'm correct in terms of the time there. Maybe it's a bit in France talking that it was started here in the mid-80s. Maybe it was before. Laurent can amend that. But as far as I know, it's this kind of introduction of let's have a look at the heart by the four-chamber and hope that with that we're going to detect a lot of the cardiac abnormalities. So it's quite a long time from mid-1980s. And we're still far from being able to detect the majority of cardiac abnormalities because the four-chamber is only part of the heart. And also, this image is from about 4 or 5 years ago, and the quality of the pictures at that stage. But even then, we still don't always get that picture. There's always that difficult-to-scan baby where you're trying to find where's the heart, the baby's all curled up, and you have to do a bit of gymnastics with your hand, move around the maternal abdomen, and eventually you get a picture of the heart, and you concentrate on that, and you apply all the techniques to improve the quality of that picture. So all of that comes to scanning, but you can come as well for ladies like this. It's low risk, where BMI of 41, big depth here before you can get to the heart, and perhaps all the sonographers could see here was that the baby's alive. You can just see the flickering of the heart. And then really you have to concentrate on the technical aspects of the image, narrow down here, improve the quality of that as much as you can to be able to come to a four-chamber that resembles that good four-chamber I showed you to start with. So really on the easy patient, it's very nice to look at the pictures and immediately you know that 4-chamber is normal. But if you have some of these difficult patients, you really need to have that piece of paper from the guidelines or any kind of checklist that you have in your mind, and you have to try and go sequentially to make sure, particularly in the difficult patients, that you're not going to miss on looking at something that may turn out to be quite important. So if you start with a more general aspect of the 4-chamber view, we look at the situs position, and you see that in here, in that general aspect of looking at the heart, there are 2 points that I think, 3 issues that I would like to point out. When you look in the heart as a whole in the chest, we're looking at situs, looking at position, and we're making sure that the majority of the heart is on the left side. So although that's not explicitly written in this checklist, how can you know that things are on the left side? And that comes to laterality. So before you even get to that checklist, the first step to checking the heart if the 4-chamber is normal is to make sure that you've worked out fetal laterality. So you need to know, according to fetal position, I'm sure you know, but you know how to do that, but the point is you have to do that at the start of the cardiac scanning. And we end up at the end of the day with isomerism, and you'll see how much important that is when it comes to complex abnormalities. So don't take for granted that the heart is on the left side, the stomach is on the left. Work out how the baby's lying, and then you come back to that list, and then you can say, yes, the heart is on the left side, and so forth. So having looked at that general aspect of the 4-chamber, we don't concentrate in separate parts of the heart, starting in a way logical from the top, the atria, making sure that they are more or less equal. So the heart is symmetrical. Right and left side, the structures are more or less the same size. We look at the details, the foramen ovale, and then we look at the atrial septum. Then we move on to the ventricles, so moving sequentially in the way the blood goes. Again, they're more or less equal in size, right and left. We kind of get used to wall thickness, make sure there's no hypertrophy. We need to recognize the moderator band because that tells us which is the right ventricle. Don't assume the right ventricle is on the right side because sometimes it's on the left. So you need to identify anatomical points that tells you which structures are which. And then we come to the atrioventricular valves. Again, we need to see them opening and closing separately. We need to look at the offset, because the offset, the lower one, closer to the apex, is that identifies as a tricuspid valve, which comes together hand in hand with the right ventricle. So let's go back to our nice, and hopefully you try and optimize your pictures 4-chamber view. So your checklist goes through your mind as you're looking at that. Well, heart here, you've worked out already that this is the left side of the baby, so this baby would be head towards you. Left side here, right side there. Then you look at the heart size, and that is in comparison to the chest size. So heart area, about a third of the area of the chest. You have the cardiac apex pointing to the left, and if you look at the interventricular septum and the anteroposterior chest wall diameter, that angle is roughly 45 degrees. You look at the heart contractility, the rhythm. All of this is eyeballing. You look to see that you do have 4 chambers. It's only now that we come to the 4 chambers. We have 4 chambers. They are symmetrical, right and left more or less the same. The wall thickness is approximately the same. Then we start from the top chambers. We see the atrial septum. We see the flap valve, which should be flapping within the left atrium. We look at the 2 atrioventricular valves. We do need to see that they're opening and closing, and you can always freeze your image on your machine as you're scanning and make sure that you're really happy that they open and close separately. Otherwise, you could miss a common atrioventricular valve, the smaller defects. You need to make sure that you see the offset of the atrioventricular valves, this crux of the heart, where the right-sided valve is here and inserts more apically. That identifies this as being the right ventricle. We also see the moderator band, another feature of the right ventricle, so we know that the right ventricle is on the right side, and therefore the left ventricle is on the left. And that's about it. The ventricular septum is intact. So quite a lot of things, but in a good image, you don't really, you just look at it, and if you experience reasonably well experience, and then you can see very clearly that's a normal 4-chamber view. So it's very easy, really, but it's surprising how many abnormalities of the 4-chamber view, including atrioventricular septal defects are not detected prenatally. And being a cardiologist, we do come across quite a significant number of babies born with the diagnosis of trisomy 21 in particular, and quite an obvious atrioventricular septal defect where the anomaly scan was just passed as normal. So maybe in general, the prenatal group are not aware of the many babies that are still being born without prenatal diagnosis. So although it's a very simple way of looking at the four chamber, we're not quite there yet in terms of the screening. Then we moved from the four chamber to the extended basic examination, and that was introduced in two levels to say, you know, if you're happy with the four chamber, look at the outflow tract. And I'll come back to this one here. And the technique is very easy. If you can get your four chamber, there are two ways of doing that, really. One, if you have your probe there, you can either slide your probe up towards the baby's upper mediastinum, or you can just tilt the probe, whichever one is easier. Sometimes one works better than the other. I tend to just tilt the transducer because once I find an ultrasound window, that gives me a good image, and I just angle the probe up and down, like in this diagram. And the further up in the mediastinum you are, the more towards the outflow tracts you're going to be. And that movement can be very, very gentle. So this is a cartoon here showing that you've got your left ventricle, you've identified your four chambers, and as you move upwards here comes a vessel in between the two atrioventricular valves. So in the normal heart, that would be the aorta, but you'll have to show that that's the aorta because obviously in transposition that would be the pulmonary artery. So the left ventricular outflow tract only tells you there is a vessel that is coming normally from the left ventricle. And it's up to you to identify that that is the aorta, and that becomes a very short clip. You can see there is very, very little. Within a long loop, you only need a couple of seconds if you're doing that scanning very slowly. If you think of your stick, if you're using that, if you do a stick very slowly, you get more definition. So this here, when you're doing your scanning, you do that as if you're doing a stick. Think that you're going to do the whole sweep in 15 seconds. So you can see all the details of every single step. So here we start with the four chamber. We've gone through that, the moderator band. You can see it's very close to the four chamber. That's the AV offset. That's the aortic valve. And really, if you're doing the left ventricular outflow tract, you need to make sure that you see the continuity between the interventricular septum here and the anterior wall of the vessel coming off the left side, which we're assuming here is the aorta, but up to this stage we don't know. That could easily have been the pulmonary artery. So very simple, continuity between the left ventricular outflow tract and the vessel coming here, and that vessel is, we call it wedged between the tricuspid and the mitral valve. So it's just in between the two. It's the central vessel in the heart. That's slightly different angle. The other one was the apex at the top is at 12 o'clock. This was the apex laterally. And sometimes, if you're not in a perfect four chamber in terms of a transverse cut, but slightly angle to get an angle that goes from left hip to right shoulder, you can elongate the left ventricular outflow tract. And that makes it easier to identify that this vessel is indeed the aorta, because it's pointing here towards the right shoulder and it's not bifurcating up to that level. But then, again, it's important to see the semilunar valve, in this case the aortic valve. We stop with it open, and then we go back, and the valve is closed, and it's very thin. You hardly see it. And then when it opens, you should not see it anymore. It's gone. So it closes, and it opens, and it closes, and it opens normally. So all of these details really should be part of the screening. And once you have a good image, freeze your image and then go back like I'm doing here to make sure that you can see the valves opening and closing. In that way, you can see the continuity here more clearly. Then a little bit further up from that towards the upper chest, we can get the right ventricular outflow tract. So it's the left ventricular and the right ventricular outflow tracts, which are part of the extended screening, and they cross each other. So it's the crossover of the vessels. So the aorta would have come here, and there is the right ventricular outflow tract. And again, it's that slight tilting of the transducer upwards towards the baby's head. So we have the right ventricle, and then we have here the bifurcation. You see that in this image here, we're already coming to what now you know is a three-vessel view. But we didn't talk too much about the three-vessel view on the 2006 guidelines. And all of these are very close together. Remember, the valves only measure about 3 millimeters at this stage. So any movement, if you do it too quickly, you miss the information. So try and do your scanning slowly, gently. providing the baby is reasonably cooperative. So in here we have the right ventricle, the pulmonary valve is there. We have a bit of the bifurcation there. I'm just highlighting it for you. And we also see that although this is called right ventricular outflow tract, it's really coming up to your three-vessel view. So there is no separation, four-chamber, left, right, three-vessel view, three-vessel trachea view. It's all part of a continuous spectrum. We divide them in different views so you can get used to some of the structure, but you should see it as a continuous sweep. So there we are. There's your left ventricular outflow tract. There's your right ventricular outflow tract. It's even difficult sometimes to keep the clip so short that we can actually see the difference. So we start with the left ventricular outflow tract. And I'm just going back. So the left ventricle is here, the beginning of the aorta, the pulmonary outflow tract. The aorta that was coming there is now here. There we are. And if we keep the probe there, there we have the aorta, and that's our superior vena cava. So again, this is done on the baby with the apex pointing here at 9 o'clock. And you see again, if you change the direction, the same information is there, and it might just look slightly different. You're just taking a picture from a different angle. So here's even more clear the left ventricular outflow tract, the crossover of the right ventricular outflow tract. And you should try and do the same. See that the pulmonary valve is there. It's thin, it opens well, and it closes. When it opens, the same, you hardly see it. And when it closes, it's there as a thin line. And then we have the aorta and the superior vena cava. So we can't really separate the right ventricular outflow tract from your right ventricular outflow tract three-vessel trachea view. Three-vessel and three-vessel trachea view. You see, at the end of this clip, we've already seen the trachea here, and a little bit lower down, sometimes you see the two bronchi separately. So that was it, really. All of those guidelines had a good four-chamber view, but you go into the details of that to get a good screening. And then it moved on to the extended basic, which is really the left ventricular outflow tract and the right ventricular outflow tract three-vessel view. Unfortunately, that word sticks in there, if technically feasible. Well, it has to be that because you can't introduce someone, some guidelines, and expect that overnight everyone is going to be able to do everything. And again, the international aspects of the society means you're producing these guidelines for a country like in France, where good screening, Italy, and again, a country where people are just starting to do the screening. So there has to be a balance, but also you want to keep the standards high. You want to achieve a minimum standards in screening. And it's also 5.5 years since it was published, so there is an update in progress, and hopefully that will be published still within the next few months. By the time of the next Congress, we hope that we'll have that in place. And I'm just going to take you through what we're going to, major changes we're going to do to that screening guidelines. So that's our 2006 basic and extended basic, and the 2012 guidelines. It's going to say something like, for performing the cardiac screening examination in the second trimester, one should include the four-chamber and outflow tract views. So now they're all part of the same. We don't have the basic and the extending. So if you want to do a good screening based on 5 years down the line, we have many more publications, much more training, better equipment, people are much more interested. You're all coming to courses like this, and lots of people attending courses. Really, we should try and push harder if we are to improve detection rate of congenital heart disease. And that is taking us more into that kind of well-known diagram, one of the publications by Cynthia Yagyel, which is the kind of 5 planes for using screening, starting from the cytos. We concentrate a bit more of that on the isomerism talk at the end of the day. 4-chamber, basic screening, the left ventricular outflow tract and the right ventricular outflow tract, which is kind of 3-vessel view. Extended screening, and we're now going to go into more the 3-vessel trachea view. So we are going to have to get used to all of these and how to interpret everything if we are to comply with guidelines and try and improve our scanning and screening techniques. So this is a nice clip, and it's going from a basic screening, 4-chamber, an outflow tract, the right ventricular outflow tract, the 3-vessel and 3-vessel trachea view. So this is your stick. Everyone is interested in stick, 4D, 3D. Well, you can do it on a 2D, do it slowly, try and find the same as you do when you're trying to get your stick, and then just follow. And you're still better than the computer, because if the baby moves a little bit, you can see. You can still follow the instruction. If the baby moves and you're taking a volume, that's it. The volume is gone, yeah? So don't underestimate how much you can see on the information. Do it slowly. And this is a very nice clip, and I've shown bits of it separately, but this, I'm not quite sure how many seconds there are, 14 seconds, yeah? So it's a slow stick. From situs, you would have worked out the right and the left of the baby. That's the left side. The stomach is there, the aorta to the left of the spine, the inferior vena cava to the right. As I said, we'll come back to situs at the end of the day. Then as you come up, you get your atrial chambers, your 2 valves. You make sure that it opens and it closes. Then you have your 4-chamber, symmetry between right and left, position of the heart, size of the heart. And then you can go into your left ventricular outflow tract, the aortic valve. I've broken this down already on the previous slides. That's your right ventricular outflow tract, coming up to the 3-vessel view. And a little bit more, you have your 3-vessel trachea view with the trachea here and the transverse aortic arch. So 15 seconds in a good scanning. So let's talk a little bit more about the 3-vessel view and try and break down. Again, we need a checklist of things that you're going to look at the 3-vessel view. And we've gone through that, and you've seen, well, there's a normal 3-vessel view. You're more than used to that. But if you're not used, or if the images are not good, or your baby's not in a good position, it's even more important that you go through, do I see 3 vessels? It's like the 4-chamber. The 3 vessels, the number is only the beginning of the 3-vessel view. You need to see more than 3 vessels. You see the number, you need to look at their arrangement, the size, relative size, and what we call alignment. So we're starting off here with the left ventricular outflow tract, and my kind of diagram here of the 3 vessels will take you through that in the next few slides. So we've gone through this picture already, the left ventricular outflow tract, and it comes here, and you get your right ventricular outflow tract and your 3-vessel view. So there, it doesn't come with labels. You're going to have to work out which is which. Important that you would have worked out already when you're doing your 4-chamber which is the left side and which is the right side. So you know already in space where those structures are. So we have 3 vessels here, and in the normal heart, from left to right, you should have 3 vessels, and they are the pulmonary aorta and superior vena cava. From left to right, it should be in that particular order. You need to look at their arrangement, their size, and the alignment. And I'm just going to take you through the next one with the diagram here. So those are our 3 vessels. Yes, we have 3. The arrangement is their relative position. As I said, from left to right, we need to have the pulmonary artery, aorta, and the superior vena cava. How do you know that those are those vessels? Well, we'll assume they will be, unless you can see the bifurcation, you can see the aortic arch, but it's a combination of everything. These 3 vessel views should not be taken out of context from everything else that you're seeing. This is a continuation of your 4-chamber, your left ventricular outflow tract, and your right ventricular outflow tract. So you're not seeing these pictures in isolation. You're seeing this in the context of the rest of the screening that you're doing. And their size, the pulmonary artery, should be slightly bigger than the aorta, and the aorta is slightly bigger than the superior vena cava. You don't necessarily need to be making measurements the whole time. Now, also, this is a perfect image. If the baby's all curled up and you're looking from one side or the other, you need to adjust. You need to look at those vessels and make a judgment at the end of the day that you are happy that the pulmonary artery is just a little bit bigger than the aorta, and the aorta a little bit bigger than the superior vena cava. And sometimes very, very minor difference in sizes here may mean a big problem. Like you may have a pulmonary artery the same size as the aorta. It may just be that there is tetralogy of Fallot, for example. The pulmonary artery is smaller. Or if the aorta is the same size as the SVC, it may be that you have coarctation in that baby. So very fine things, very subtle changes may imply a big problem. And finally, we come to the alignment. And if you look here, we can see from anteroposterior in the chest, the pulmonary artery is the most anterior, i.e. closer to the chest wall. The superior vena cava is the most posterior one, and the aorta is in between. So that those 3 vessels form this kind of straight line, yeah? So they align anteroposterior more or less in a straight line. Now we're moving again in that continuum, just slightly higher up from that 3-vessel view. And we come to the three-vessel trachea view. That's the name that has been accepted in a way, but some people prefer to call it arch view because you see more of the transverse aortic arch rather than just the aorta as a little circle here. And again, this is just a tiny movement of the transducer in the majority of babies. You see the trachea here, but you also see it in the three-vessel view, even in the right ventricular outflow tract view. And sometimes, as you go down, as I said, you may even see the two separate bronchi here. Display that one again. So I'm not quite sure in terms of time. I'm ahead of time. So you might say, well, are we having a big step between 2006 and 2012? Are we trying to achieve too much? Is our goal too high? I think it's up to you to decide. Some people might find, well, I'm not quite happy with the four-chamber yet. Or that might be very comfortable up to the three-vessel view. You may be using color already, so it's very difficult to say to people, this is what you should do, because I think there's always room for more. And I'm not putting this on a slide, and quite a few years ago, someone asked me in one of these meetings, yes, but what is the minimum I should do for screening? And what do you think the answer to that should be? Forget about guidelines. They should ask you that question. What's the minimum I should be doing? Any guesses? What would you say? You know, someone, if you're a fellow visitor, what's the minimum I should do on the heart? Or in anything? Yeah? Someone wants to give me an answer?
Yeah, well, I would say whatever you do, do it, but you should at least have about 60 to 75 detection or sensitivity. How you do it, that's up to you. I think a good screening program, having proper equipment, and let's say Western European countries, one should reach 70% at least. If not, there's something wrong with your screening.
Yeah.
How you screen, that's up to you. As long as you achieve it.
Yeah, how your screening is, I entirely agree. I think, there are lots of answers here. You can justify lots of things, but I think you should ask yourself, you gave a good answer. 60% is quite high. The national guidelines in the UK now, the aim detection rate at the national level is to achieve 50%. There's a paper from the UK from around 2000 more or less, which showed that the detection rate is about 23% overall across all places in the UK. In Europe at the same time it was the same, 24-25%. If you go to specific areas, in our hospital it's about 70-75%, for low-risk populations, so it varies a lot. Now, how you screen, you may use nuclear translucency, but when someone individually is asking, what should I do? Well, follow the ISUOG guidelines. Okay, if I follow that, if I do all that, I'm happy. Well, my answer is really, you should always do a bit more than what you're doing. Yeah? I think everyone is at a different level. If you're only doing a four-chamber, well, don't get stuck on the four-chamber. Just start moving your probe, a second more, and you see a lot more. If you're happy with everything I've shown you, put color. Look at sagittal views, do other things, yeah? So always push yourself. There is always room for improvement, always. So if you're doing all of that, maybe you start using color, yeah? Color helps. I haven't touched color because the ISUOG guidelines, even in the new ones, we're not going to be pushing color. But color is extremely useful. No one does fetal echo without color. That's doing fetal echo, and that's the difference between our scanning and the screening that we talked about. So now we're going to spend a little bit of time going through a bit more of that screening. Screening is, well, I think there's something wrong. Yeah, sometimes I get a referral, I'm not happy with the aorta. I thought, fine, said the patient. Yeah, because sometimes I'm not happy with that aorta means slightly big, maybe aortic stenosis. Yeah, maybe a tetralogy, maybe something else, maybe a chromosomal abnormality. So screening, you just need a hinge. I'm not happy. I scan lots of papers. I'm not happy with this one. For some reason, it's good reason enough for referring the patient. So the scanning is more the consensus statement. So that's separate from the screening guidelines. And I can tell you, I was part of both groups, and it was much harder to say, for us to agree on what is a fetal echocardiogram than to tell other people what to do. you should do this, and that. It's very easy, in a way, to do the screening guidelines. When it came to what do I do, what does Dario do, what does Rabi do, what does Lindsay Allen do, we all do it in different ways. So the important thing is that you cover all areas. How exactly, comes to the point, how exactly you do that is up to you. You don't necessarily need to get all of those standard views if you can get the information from a different angle, in a different baby, in a difficult baby. So what constitutes a fetal echocardiogram? So this, again, I ripped this off from the 2006 guidelines, or consensus statement, 2008, I beg your pardon, 2008, and that's coming up to 4 years now. And that list is not really dissimilar from what we discussed before, except that you should pay even more attention to all the details. But perhaps here, what's not on the other one is, in the fetal echo, you need to look at the flow across each heart, each connection, make sure that everything flows nicely and smoothly, the color flow mapping is good. And we do have more of a chance of detecting ventricular septal defects, because not all of them are very obvious. There are some defects, which is called in between the fourth chamber and the long axis view of the left ventricle. Those can be quite hard even for the specialist to see sometimes. And we have to use all the tools we have in our hands to try and refine the diagnosis, because it's only after you make a precise diagnosis that you can counsel the family. So there's a nice color flow map. If you haven't yet, I think we're still going to hear about color flow, how you use that, so I'm not going to comment on that, but you should try and get the best color possible. It's not always possible, it depends on the depth, the size of the woman, the position of the baby, but nice, smooth color within your range, and you can see details of the ventricular septum, in between, no flow going across, but only if your color is perfectly adjusted for the best you can for individual patients. You're not always going to get as good an image as this one. That's your left ventricular outflow tract, and your right ventricular outflow tract, and your three-vessel trachea view, and it's nice and smooth, flow in the same direction, less the trachea. So the use of color is mandatory if you're doing a fetal echo, because you can't judge, really, certain things, and sometimes it just gives an information that without the color you cannot see. There are other color modalities as well, and different manufacturers will use different names, they have slightly different settings, but what we showed before was the conventional color flow mapping, tells you about velocity, it's angle dependent, but it tells you velocities, which is important across the valves. The other ones, they're less angle dependent. Sometimes the image, you can do a preset that's different to tell you different information. You can have bidirectional on them. Sometimes you can have one color. Sometimes it works better in one way for one patient. So play around with that. Learn what you have in your equipment to try and get the information. So all of these will tell you information. You can see here pulmonary veins coming to the left atrium. You can see the bifurcation of the pulmonary arteries, the right and the left, and the arterial duct coming here. I quite like having this. I've always used this kind of split image, because if you're not used to color, and if you're coming to color as a novice, and then you can see your aorta coming up in the middle, wedged between the two valves, and then after that, before you come to your three-vessel view and ductal view, there, and the trachea, if you go down slowly a little bit, you can see the bifurcation of your pulmonary artery, the right going to the right, the left coming here. So again, a slow stick movement, paying attention to all the details. I think at the end, we may or may not have had a bit of flow through the azygos joining the superior vena cava. So you try and extract as much information as you can. So just go back to that. I'm put here in smaller letters because we can't talk about everything today. So the M mode that's used in selected cases, spectral Doppler, you look at the rhythm. There are different ways of looking at the rhythm. Some people prefer M mode, some people prefer the left ventricular inflow, outflow tract. I like more the pulmonary artery, pulmonary vein Doppler signal for rhythm. So there are other things you can do to try and refine that diagnosis. But more important as well, we don't stick to that upward sweep, transverse sweep. There is a multitude of views. It's like you look at the person from the front and you say, okay, I'm looking at you from feet, abdomen, chest, and head. So I've done my stick. Well, if you go around and look at that baby's back, at that person's back, or from the side, or the person move, so you can have an overall view. You can have much more information about that person than if you're just taking a picture, AP picture, anterior posterior. And this is a relatively short clip here where we start from a slightly elongated left ventricular outflow tract, and you can see how the ribs are changing. You're not transverse anymore. And it's a good exercise to do that sweep now from transverse views to sagittal views, because you can follow the structures. If you don't know how the left ventricle is going to appear in a transverse view, in a sagittal view, if you just keep your eye here on that structure, and as you're moving across, so you're just rotating from transverse to sagittal, and you can see that structure becoming a round structure, and then eventually you get your mitral valve opening and closing. That's difficult to do here. It's easier on your machine than it is here. As the mitral valve open and close like a fish mouth. So in that way, you can follow all the structures. If you're not used how they look like, you can just smoothly change from one plane to another. And of course, you can do a sagittal sweep from right and left the baby this way, rather than up and down, and then you come to your superior vena cava, your aorta, and then eventually your pulmonary arteries. So we're looking here at the three-vessel view, but instead of looking at them here on the transverse plane, we're looking at from left to right the pulmonary, the aorta, and the superior vena cava, or from right to left the superior vena cava, the aorta, and the pulmonary arteries. So that in here we're starting with the inferior vena cava coming up, the diaphragm is there. So you're used to those images. You can see with and without color, just starting to see the superior vena cava coming here, superior vena cava into the right atrium. It's a bit of the right atrial appendage. And then you're moving into the left, you see your aorta. So that's your second vessel on the three-vessel view. And if you move a little bit more to the left, that's your pulmonary artery coming here from the right ventricle. So it's the same structures, but it's just seen from a different angle. So all of that tells us a lot about the heart in different views, which is what we do a lot in fetal echo. Now, I'm going to give you one example of refining diagnosis, which is tetralogy of Fallot. Because tetralogy of Fallot is a common abnormality, and I'm sure and hope that a lot of you would have picked up at least one tetralogy in your how many years or months or decades of scanning the fetal heart. So let's refine the diagnosis of tetralogy of Fallot. And this is a picture that shows you the left and the right ventricle and a ventricular septal defect, which is part of tetralogy with overriding of the aorta. So some of you might see a ventricular septal defect and say, oh, this is tetralogy. Well, there are ventricular septal defects in tetralogy, in truncus, in pulmonary trees, in lots of things. So, oh, yes, I can see overriding, so that's tetralogy. Is it? Well, it could be transposition with a VSD and an overriding pulmonary artery. So one thing doesn't tell you it's a diagnosis. More than that, for tetralogy, we need pulmonary outflow tract obstruction. So we're coming to our four things. And the fourth one is right ventricular hypertrophy, which is not really a feature in fetal life. So to make the diagnosis of tetralogy, we need a ventricular septal defect, we need an aortic overriding. So we need to know the vessel overriding the aorta, and we need to have some evidence of pulmonary outflow tract obstruction. So that's kind of beginning of the diagnosis. Well, let's refine it a bit more. What is more in tetralogy? Well, you can have tetralogy with pulmonary stenosis. You can have tetralogy with pulmonary atresia. You can have tetralogy with absent pulmonary valve syndrome. So there's different aspects of tetralogy. So it's not good enough to say this baby's got tetralogy. You need to specify a bit more so we know what the management is going to be and what the outlook long-term might be for that baby. So that's a picture of a tetralogy with pulmonary stenosis at 21 weeks. We started off with right and left ventricle, coming back to the beginning of the loop again. That's the aortic overriding. You see flow going to the aorta. You see the pulmonary outflow tract. And if we come to our three-vessel view here, you see the pulmonary here is smaller. So if you had missed that VSD, which might not be so easy if you don't stop it, and the aortic override on your no color here, that's the no continuity here between the septum and the aorta as the path of ventricular septal defect. And then crossing from the right ventricle, we have the pulmonary artery, which is smaller than the aorta, so that's our indirect evidence that there is pulmonary outflow tract obstruction. So we are coming to our three-vessel view. Yeah, pulmonary aorta and superior vena cava. This is not what we expect. Yeah? The aorta is actually a little bit more anterior here. The pulmonary is smaller than the aorta. It should be the other way around. The pulmonary should be bigger than the aorta. So the VSD can be quite difficult to demonstrate. At screening level, you might detect that by showing a pulmonary artery that's smaller. So if you're doing a fetal echo, you need to measure the aortic valve, you need to measure the pulmonary valve, showing that the pulmonary valve is smaller. And if you don't have color, you don't know if there is flow there, because there might be no flow across the pulmonary outflow tract, but you have color, you can see there is forward flow. So tetralogy with pulmonary stenosis, so that's one group. Tetralogy with absent pulmonary valve syndrome is quite rare. It's usually easily detectable because you have this huge pulmonary artery. So it's the opposite of the usual tetralogy where the pulmonary artery is smaller. These are usually very large. You have no proper valve here, so you have stenosis as the flow going to the main pulmonary artery, and you have regurgitation. So it's a to and fro flow across the outflow tract. It's completely different management in terms of counseling the family and so forth, different problems. That's when it comes to fetal echo rather than screening. And then you have tetralogy with pulmonary atresia. You might just say, well, okay, tetralogy with pulmonary atresia, there's no flow to the pulmonary artery, but then you have to refine the diagnosis even more. You can have tetralogy with pulmonary atresia and central pulmonary artery supplied by an arterial duct. You can have supplied by collaterals and minute pulmonary arteries, and you can have it with a combination of the two of them. So all of these will tell you a lot about how to counsel that family. This is an example of tetralogy with pulmonary atresia. And although you see a vessel here, if we put the color, you see that the flow is reversed. So this is telling us, in this case, it's coming from the arterial duct. So it's a duct-dependent circulation. Another case, again, with pulmonary atresia here, large aorta, and from the descending aorta, we see collateral vessels. We can identify them. They have a characteristic Doppler pattern. You can see them here from the descending aorta going to one lung, going to the other lung. So the supply here is not from the duct. It's completely different prognosis and management for these babies. And sometimes you can identify very, very small pulmonary arteries. So this is more fetal echo. If you're doing fetal echo, you really need to get more information so that you can counsel the families only after that. So tetralogy is not enough. You can see how many other things you have to look for. There are, of course, I'm about to finish. There are, of course, other things on the fetal echo that are important. So the cardiologist is not the almighty God there. We have chromosomal abnormalities, we have extracardiac abnormalities. So defining the diagnosis is not just looking at the heart, it is looking at the baby as well. So that's, I think it's my last one, is that another piece of paper that we take from the 2008 publication is a teamwork. Accurate diagnosis is essential. Multidisciplinary counseling. This is all part of the fetal echo. Pediatric cardiology involvement, maternal fetal medicine, because we have to see the extracardiac implications. Imaging, neonatologists, in case the baby needs prostaglandin to start with. Genetics, genetic syndromes associated. Surgeons and what we expect to do with that patient. Social work, there are lots of problems involving families that may have a child with a major abnormality, and not infrequently we do have to refer these mothers for counseling, either because they just can't cope, there's a termination or whatever. So teamwork is important when you're doing a fetal echo. And the other thing is to remember your limitations. Yeah, I think we all have those labels that we might go through our washing trying to sort them out, or try and learn as much as we can about what we're doing. But if we don't know something, go and ask someone that might know better. Thank you.
Thank you,
I should have
Jolene.
put Merci here.